Good day, doctor. This is group 3. Our topic is bleeding and thrombosis. What is bleeding? Bleeding is the loss of blood from the circulatory system which can occur either externally or internally. Causes can range from small cuts and abrasion to deep cuts and amputations. Hemostasis. Hemostasis is the process that stops bleeding from a damaged blood vessels. It involves 3 main steps. Vasoconstriction, also known as vascular spasm. Blood vessels constrict to reduce blood flow. Platelets plug formations. Platelets adhere to the injury site, becoming sticky and forming a temporary plug. Fibrin clot formation. Clotting factors convert fibrinogen into fibrin, creating a mesh that stabilizes the platelet plugs, forming a stable clot.
Now I am going to say about the platelet activations. Injured endothelium releases 1 millimole factors that will go and bind to these underlying exposed collagens. Platelet have a glycoprotein 1b receptors. By these receptors, it binds to these 1 millimole factors. Now the platelets attaches to the non-platelet surface, and this is a platelet adhesion. When the 1 millimole factors activates glycoprotein 1b receptors, and these receptors give signals to the platelets, and in the platelet membranes, the phospholipases enzymes break down the phospholipid into arachidonic acid, and the arachidonic acid breaks down into the thromboxane A2, which is a vasoconstrictor and also a platelet activators. And also the platelet releases granules like alpha granules and delta granules, whereas the delta granules like serotonin, which is useful for these vasoconstrictions, and ADP useful for platelet aggregation. Now the platelets start aggregating and forms a primary platelet plugs. Within the intrinsic mechanism of the blood, there is a factor number 12. When it touches the non-endothelial surface, it activates the coagulation cascade by the intrinsic pathways. Activated platelet and an injured endothelium cells releases the tissue factors, which activates the coagulation cascade by the extrinsic pathways. Whether it is an intrinsic pathway or extrinsic pathways, the both are ends in the same cell, like a conversion of soluble fibrinogen into insoluble fibrin strands, and these fibrin strands get deposited on these platelet. And the fibrin stabilizing factors cross-link these fibrin strands and make a meshwork and a network of fibrins. Now the primary platelet plug is converted into the secondary platelet plug. Thank you.
Antithrombin mechanism. Antithrombin is a vital regulator of blood coagulation, acting primarily as an inhibitor of key enzymes in the coagulation cascade. By binding to and inhibiting thrombin and factor X as well as factors 7, 9, 11 and 12, antithrombin prevents excessive clot formation, maintaining hemostatic balance and reducing the risk of thrombotic disorders. History of bleeding. Epistaxis. Common, especially in children and dry climates. Heavy menstrual bleeding, frequent in women with bleeding disorders. Postpartum hemorrhage. Common in women with bleeding disorders. History of PPH increases the risk of recurrence in subsequent pregnancies. Pro-hemorrhagic effects of medications and supplements. First, aspirin and NSAIDs inhibit cyclooxygenase 1, impairing hemostasis, can cause severe GI bleeding. Other NSAIDs effects are reversible. Second, ADP P2Y12 inhibitors inhibit ADP-mediated platelet aggregation, higher bleeding risk than NSAIDs. Third, herbal supplements, fish oil, omega-3s and vitamin E. Fourth, patient management, review and discontinue medications linked to bleeding. Now, underlying systemic disease and bleeding tendency. Common cause of acquired bleeding disorders: liver failure, thrombocytopenia. Liver failure and coagulation impairs clotting factor production. Thrombocytopenia. Reduced platelet count increases bleeding risk. Bleeding risk factors in thrombocytopenia: severity of platelet reduction, procedural risks, procedures and platelet counts. Assess and manage platelet levels before procedures.
History of thrombosis. First point is the overview. Thrombosis involves the formation of blood clots within a vessels, leading to complications such as deep vein thrombosis and pulmonary embolisms. Both genetics and environmental factors influence thrombosis risk. The second point is major risk factors. Arterial thrombosis, often associated with atherosclerosis. Venous thrombosis, influenced by factors like immobility, malignancy, and surgery. Third point is key historical point. Idiopathic versus precipitated events. Idiopathic events strongly predate recurrent venous thromboembolisms, while precipitated events often relate to underlying conditions like cancer or recent surgeries. Age. Thrombosis risk increase with age and family history, a significant indicator of genetic predisposition of thrombosis. The fourth point is indication of past thrombosis. Treatment history, previous treatment for thrombosis and recurrent risk, assessment of ongoing risk for recurrent thrombosis. Now the screening assays. Prothrombin time, factor 1, 2, 5, 7 and 10. Activated partial thromboplastin time. Intrinsic and common coagulation pathways, factor 11, 9, 8, 10, 5 and second. Platelets count, thrombin time and reptilase time. Measure fibrinogen conversion to fibrin. Anti-factor 10A activity used to assess levels of low molecular weight heparin, unfractionated heparin or direct 10A inhibitors. Testing for thrombophilia. Indications. Testing should be limited to cases where results will change clinical care.